the community. Thank you.
Question 5, Ms. Judy Chan. It is learned that at present, the obstetrics and gynecology departments of public hospitals encourage pregnant women to opt for natural delivery whenever possible, and cesarean sections will only be performed under specific circumstances. In this connection, will the government inform this council, 1. Whether it knows the respective criteria adopted by public hospitals for encouraging pregnant women to opt for natural delivery and determining to perform C-sections for the pregnant women concerned? 2. Whether it knows the number of C-sections performed in public hospitals in each of the past 5 years and the respective reasons for performing the surgeries, together with a breakdown by type of hospital ward? And 3. As it is learned that at present, public hospitals in quite a number of countries allow pregnant women to opt for C-sections, whether the government and the hospital authority will make reference to international practices and review the existing policy of public hospitals on C-sections, if so, of the details, if not the reasons for that, and whether the relevant review will be conducted in future. Secretary for Health. President, Hong Kong is one of the regions with the best obstetric services, and it is a place with the lowest neonatal mortality rate and maternal mortality rate. In 2025, the neonatal mortality rate in Hong Kong was 1 per 1,000 live births, and there were no maternal deaths during childbirth. We attach importance to providing appropriate obstetric services for pregnant women. We adhere to the principle of evidence-based medical practice. We provide comprehensive risk assessments for pregnant women, and we have professional teams arranging for natural delivery for the pregnant women without medical evidence. Our teams would arrange for pregnant women to experience natural delivery, and C-sections are only for those who are not suitable for vaginal delivery. Vaginal delivery is a natural physiological process. It enables quick recovery. Studies showed that vaginal delivery can prevent pregnant women from certain risks. It also allows pregnant women to get out of bed within a few hours postpartum. For those who experience C-sections, they need a longer time for recovery, and they usually take 12 to 24 hours postpartum to get out of bed. Compared with C-sections, for those who opt for vaginal delivery, they experience fewer risks such as vomiting or nausea. Vaginal delivery can enable quick recovery, allowing mothers to accompany their newborns, and women who undergo vaginal delivery, they can breastfeed their babies easily. And vaginal delivery could also ensure a lower risk of neonatal respiratory complications. C-sections are major surgical operations. It could lead to risks such as surgical site infection as well as a longer stay of hospital, according to statistics. The risk of surgical site infection following a C-section ranges between 3 and 10%. According to data collected by the HA, the incidence rate of postpartum hemorrhage, defined as blood loss exceeding 500 ml, is 34.9% for C-sections, compared to only 9.1% for vaginal deliveries. It's 4 times higher. Also, C-sections may cause organ injury, with the probability of urinary bladder injury ranging from 0.1 to 1%, and the risk of developing thromboembolic disease is 3.7 times higher than that of vaginal deliveries. It may lead to long-term complications such as abdominal or pelvic adhesions and chronic pelvic pain, exerting a prolonged impact. It could also leave a scar on the uterus, thereby increasing the risks of placenta accreta, placenta previa, and uterine rupture. For infants, C-sections carry a risk of causing neonatal respiratory distress syndrome and neonatal hypoglycemia. Also, medical research indicates that C-sections are associated with an increased risk of children developing cardiovascular diseases, asthma, overweight, and autism spectrum disorder later in life. authorities around the world said that C-sections should only happen where medical necessities exist. The WHO discourages non-essential C-sections and continuously promotes various initiatives to reduce such surgeries. The National Health Commission has explicitly stipulated encouraging vaginal delivery and implementing C-section where medical indications are met be adopted as a working principle for maternal and child health care. In addition, the International Federation of Gynecology and Obstetrics, the American College of Obstetricians and Gynecologists, and the Royal College of Obstetricians and Gynecologists have emphasized that unless medical indications arise for the mother or the fetus, vaginal delivery should be routinely recommended as the primary mode of delivery. Therefore, the HA performs C-sections for pregnant women based on clear medical necessity, rather than for reasons such as a preferred delivery date and time or purely subjective choices regarding the mode of delivery. In consultation with the HA, the consolidated reply to the question raised by Ms. Judy Chan is as follows. 1. All public hospitals under the HA determine the mode of delivery appropriate for pregnant women based on the principle of evidence-based medical practice. Should any medical risk factors be identified during the risk assessment, the healthcare team will arrange for the pregnant women to undergo a C-section. 2. During the period from 2020 to 2024, the total number of deliveries in public hospitals ranged from 19,488 to 26,494 per annum, while the number of C-sections per annum ranged from 6,196 to 8,234. On average, about 30 to 35% of pregnant women gave birth via C-sections each year. According to 2024 statistics, the major clinical indications for C-sections in public hospitals include uterine scar, that is previous C-section or previous myomectomy, and the rate stands at 37.7%. Failed induction of labor accounts for 17.8%, fetal distress 14.2%, abnormal fetal presentation 13%. Other clinical indications include antepartum hemorrhage, multiple pregnancy, arrest of labor, cephalopelvic disproportion, failed assisted vaginal delivery, intrauterine infection, macrosomia, and placenta previa or placenta accreta. Regardless of whether a pregnant woman is admitted to a general ward or a private ward, the HA determines the necessity of a C-section based on the actual clinical conditions. Therefore, the HA currently does not compile breakdown statistics according to ward types. As for the last question, as stated above, multiple health authorities worldwide have pointed out that C-sections should be reserved for cases with clear medical needs. Non-essential C-sections should be discouraged. Out of consideration for safeguarding patient health, the HA currently has no intention of adjusting the existing policy on C-sections. Ms. Judy Chan. President, I've looked at the major reply provided by the Secretary. Any surgeries come with risks. I think the government's policies are a little bit outdated. The Secretary mentioned some health authorities around the world. They include the American College of Obstetricians and Gynecologists. In 2019, the American College updated its guidelines. Also, in 2024, the Royal College of Obstetricians and Gynecologists updated its guidelines. Both guidelines state that there is no strong evidence showing that we should recommend pregnant women to undergo natural delivery. So the most updated guidelines is that as long as the doctor communicates with the pregnant woman about all the risks as well as the merits of both natural delivery and C-sections, then the pregnant woman can make a choice herself. About 18% of the natural delivery leads to failed induction, and for 14.2% of cases show that there is abnormal fetal heart rate. So the pregnant woman may want to give birth at zero risk. So why can't we allow pregnant women to make their own choice? Secretary. The risks associated with C-sections do not just only affect pregnant women, but also to infants. Our ultimate goal is to safeguard the health of pregnant women and babies. Pregnant women, when considering the mode of delivery, they make a choice based on insufficient information or misunderstandings. If we arbitrarily relax C-sections policies, it would not be ideal. So we need to adopt a risk-based approach to safeguard pregnant women's health. We need to provide as much information as possible to pregnant women so that they understand the risks behind. Therefore, the HA provides information on HA Go mobile app. There's a function on the app that provides all kinds of information to pregnant women. We also focus on antenatal education efforts. We provide mental health support to pregnant women through multidisciplinary teams to lower the fear of pregnant women before delivery. We also provide various trainings to pregnant women, such as breathing exercise, and all these can help ensure a high success rate of natural delivery, and these are recommended by the WHO to avoid C-sections. Mr. Adrian Ho, the administration stressed that it would not accommodate pregnant women just because of their preferred delivery date and time or choice. However, there are pregnant women who are facing tocophobia. So how do you draw a line? What kind of criteria do you adopt to decide whether the pregnant woman makes a subjective choice? Frontline staff, how do they deal with such situations, or do they make a decision based on their own subjective views? Secretary. Any patient, including pregnant women, what kind of treatment they go through is decided by doctors, and it is decided based on the communication between doctors and patients. It is not up to the administration to make a decision for the patients. Every patient, before they deliver, they receive information from our healthcare teams, and they make informed decision after the communication. For example, a pregnant woman may have some special experiences, and they have personal reasons for making a preferred choice. And after they communicate with the healthcare team would help make a decision. Ms. Christine Fong. The Chan Kwan O Hospital so far has not provided any obstetric services. There is a population of over 520,000 in Chan Kwan Ho, including Hang Hao and Sai Kung. I understand that many pregnant women opt for natural delivery. So what I want to say is that hardware is important. Pregnant women from Chan Kwan O have to travel to other districts to the Union Hospital to give birth. I believe that the HA must have statistics from the previous 5 years about the time to send pregnant women to hospitals and so on. Will you come up with an arrangement for high-risk pregnant women, and would you consider expanding the capacity of Union Hospital as well as the Chan Hospital so that more pregnant women can receive delivery services in these two hospitals? Secretary. Pregnant women receive antenatal checkups. For different patients, if they go to different hospitals, they are subject to different arrangements. The member asked about whether there are obstetric services in the Chan Hospital. Well, obstetric services provided by public hospitals are divided by clusters. We want to ensure that every patient can get appropriate treatment and services. Obstetric services have seen great adjustment over the past 10 years. This is because we see a significant drop of birth rate in Hong Kong. In 2020, there were about 43,000 live births, and in 2025, the number dropped to 31,000, and it represents a decline of about 30%. So in terms of the overall service supply, we look at the demand, and based on the demand, the HA will make adjustment. Reverend Peter Kuhn. Thank you, President. Just now, the Secretary explained the merits behind natural delivery. Well, will private hospitals adopt the same criteria or standards when deciding to provide C-sections or not to pregnant women? Secretary, regardless of whether it's a public or private hospital, our doctors abide by the professional code of conduct. Indeed, there is a difference between services provided by private hospitals and public hospitals. Doctors from private hospitals, they abide by certain standards, but in public hospitals, we have a bigger healthcare team. Take the obstetric department as an example. We have a team comprising doctors, consultants, as well as doctors undergoing training. We also have midwives in our teams. In private hospitals, their teams are smaller in size. Regarding 24-hour delivery service or natural delivery service for pregnant women, well, these doctors who provide such services are subject to greater pressure. Some pregnant women may pick an auspicious time for undergoing a C-section, and such planned C-section surgery is easier for doctors because doctors do not have to make too many calculations before the labor. Well, there are merits to natural delivery. So there's a difference in terms of C-sections rate in public and private hospitals. However, it is because the two types of hospitals stick to two different mechanisms. Ms. Nixie Lam. Let's look at the statistics. In Hong Kong, 1 out of 10 women suffers from placenta presentation problems. This is because it is serious because it could lead to adhesion problems, especially for those who undergo natural delivery. This is because this kind of placenta could stick very close to uterine walls, and so pregnant women who undergo natural deliveries are subject to great pressure. I have the same problem. That's why I raised this issue. I gave birth in a private hospital, so I insisted to my doctor that I wanted a C-section. Otherwise, I might experience serious complications. In the major reply provided by the secretary, he mentioned some risks associated with C-sections. I want to know that natural delivery also comes with risks. Just now, a member mentioned that the US updated its guidelines in 2019. Same for the UK. It updated its guidelines in 2024. So I want to know if we will follow these two countries and update our own guidelines as well. Secretary, Ms. Nixie Lam talked about her own experience. I thank her for that. She mentioned endometriosis, and I believe doctors take all these into consideration. In public hospitals, about 30 to 35% of patients undergo C-sections, and it is mainly because they suffered from serious medical indications, and I named some of the indications just now. Our healthcare team would take into consideration all factors before a patient makes a final decision. It's not that we do not carry out C-sections for patients. Statistics show that we carry out C-sections for 35% of the cases. This shows that C-sections in some cases are necessary. According to our existing guidelines, we should avoid non-essential C-sections. Yes. Anything to add? Will the government follow the practices in the UK and the US to update our own guidelines? Yes, Secretary. We draw reference from practices from other places as well as from our own country. We have a team dedicated to study these practices and guidelines. Thank you.
Last question seeking an oral reply. Mr. Yin.